Thank you for joining us for tonight's update in partnership with St Vincent's Clinic. My name is Bertha Harvey and I'm the CPD and Events Manager at Central and Eastern Sydney PHN. I would like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise the continuing connection to land, water and community and pay respects to elders past, present and emerging. I would also extend that respect to any Aboriginal colleagues who may be joining us tonight. Tonight's session has also been accredited for 2.5 educational hours and 1 review and performance hour. We will submit your hours with the RACGP and the optional review and performance activity will be emailed to the GPs after the webinar. I would now like to introduce our facilitator tonight, Caitlin from St Vincent's Clinic. Thanks, Caitlin.
Thank you, Bertha. Hi, everyone. My name is Caitlin Almazri. I'm the Marketing and Events Coordinator at St. Vincent's Clinic, and I warmly welcome you to this interactive webinar in partnership with the Central and Eastern PHN. This webinar, you will hear from 2 of St. Vincent's specialists. We have Dr. Simon Ghaly, Senior Staff Specialist Gastroenterologist at St. Vincent's Hospital, and Associate Professor Santosh Sanagapalli, Staff Specialist Gastroenterologist and Director of the Centre for Swallowing and Oesophageal Disorders at St. Vincent's Hospital. Both doctors also work in private practice in the Diagnostic Endoscopy Centre located within St. Vincent's Clinic. Thank you all for joining us tonight, and now I would like to pass over to Dr. Sanagapalli.
Well, thanks everyone for joining tonight. And yeah, the title of the talk is What to Do When PPIs Don't Work, looking at inflammatory and other non-reflux related upper GI disorders. So today, I would first like to start briefly by recapping some of the evidence bases behind pharmacological and non-pharmacological reflux therapies, and also briefly touch on how to approach these patients who aren't responding. But the bulk of my talk will be looking at this condition, eosinophilic esophagitis, a relatively newer inflammatory disorder of the esophagus. And I would like you to feel like you're comfortable with the therapeutic options in EOE and even with the long-term care of these patients, as this is often shared between GPs and gastroenterologists. So briefly talking about the dietary and lifestyle factors for reflux. So of course we commonly, discuss, and these are often the first recommendations we make, but actually the evidence for dietary and lifestyle factors varies quite considerably. And by far and away, the biggest sort of dietary or lifestyle factor with the strongest evidence base is obesity. I always tell my patients reflux is fundamentally a mechanical problem where stomach acid is allowed to get up where it shouldn't be. And the biggest driving factor is abdominal adiposity, which over time weakens and loosens the anti-reflux barrier at the OG junction. And we have a lot of evidence, not just from controlled trials, but from meta-analyses that show that not only is increased weight associated with increased reflux, but even modest amounts of weight loss significantly reduce reflux symptoms and actually objective measures of esophageal acid exposure. So I guess there is also reasonable evidence from randomized trials for other lifestyle measures. So for example, bedhead elevation is quite well established to help with nocturnal reflux symptoms. And another practical intervention is avoiding late evening meals. So we have data to show that if you leave at least 3 hours between your last meal at bedtime, that reduces nocturnal reflux episodes. And this is also physiologically plausible by reducing intragastric pressure when the patient is supine. So alcohol cessation and smoking reduction, they do both have a plausible biological mechanism because they both can impact the lower esophageal sphincter, and there is some direct evidence. With regards to specific meal components, not only do we talk about these a lot, but patients often bring these up a lot. But surprisingly, there's actually not a whole lot of really high quality evidence for these specific meal components. So my approach with these is mentioning some of these common foods which are implicated, and not to tell the patient that they must never eat these again, but of course it's rational to reduce consumption of these if they note that there's a particular pattern between consumption and having symptoms. And there is at least a plausible mechanism for all these kind of foods. On the other hand, specific, macro, protein components, like fiber, protein, and the specific consistency of food really don't even have a plausible biological mechanism. And so I don't generally discuss these things. And then briefly about pharmacological reflux therapy. Well, of course, PPIs still remain the gold standard, and they have the most strong evidence base, not just for potency and symptom relief, but also for healing esophagitis. H2RAs may have some role, perhaps for mild disease as monotherapy, though they're less effective and can be limited by tachyphylaxis. On the other hand, I think antacids, particularly those with alginates combined, do have a significant role, not just as monotherapy in mild disease, but they work well as adjunctive therapy for PPIs and should be used in the postprandial period, and of course have an excellent safety profile. On the other hand, I think prokinetics have very little, if any, role in reflux, and they're often limited by significant adverse effects. So this randomized trial was actually, I thought, very informative, specifically for primary care, to tell us really what's going on when PPIs aren't working. And while the primary purpose of the trial was to compare medicine versus surgery for refractory heartburn patients, the enrollment part of it was, I thought, very informative. So these were all patients referred from primary care with what was felt to be refractory heartburn symptoms. And the interesting thing was, after complete workup, only a minority of cases actually had confirmed GORD by pH testing. So the rest either responded to simple PPI optimizations, so all they did was put them on omeprazole 20 milligrams BD. Then a big chunk had evidence of non-reflux related disorders like eosinophilic esophagitis or motility disorders, and then a small component had so-called functional heartburn, where they have symptoms but really no objective organic finding. So the key takeaway from this is actually the majority of PPI non-responders, at least in primary care, don't actually have reflux, and you need to look for an alternative diagnosis. So in saying that, a reasonable stepwise approach for reflux is pretty simple, I think. So of course, basic things that can be done even in primary care would include the usual things like compliance. Dose timing can be really important for PPIs, and we know they're much more efficacious taken on an empty stomach 30 minutes before breakfast. And sometimes that simple change in timing can really improve the symptoms. You can consider relative potency of PPIs, and for example, 20 milligrams of esomeprazole or omeprazole is far more potent than 20 milligrams of pantoprazole. If none of that has helped, then obviously the next step is investigation. And still in 2025, endoscopy is the initial investigation of choice. And I always do this in such patient cohorts off PPI, because if they're on PPI, well, first of all, it's not helping their symptoms anyway, but secondly, it masks all the findings. So we get much more diagnostic yield if we stop it for 2 weeks. Aside from trying to find any objective reflux changes, we obviously look at the structure of the esophagus and stomach, not only for hiatus hernia, but more subtle derangements or weaknesses of the esophagogastric junction. And of course, we look for alternative diagnoses such as EOE. It's important to remember endoscopy can diagnose reflux, but it never rules it out. And if we really want to go conclusively rule it in or out, we still need to do esophageal manometry with 24-hour pH monitoring. And this is still right now the gold standard to definitively diagnose reflux. So then moving on to the bulk of the talk today about this condition, EOE, we call it for short, and it is a chronic immune mediated, it's a more of a delayed type allergic reaction in the esophagus. And for diagnosis, we need both symptoms of esophageal dysfunction, but biopsies from the esophageal mucosa showing elevated eosinophils. So we require both clinical symptoms and histological confirmation. The pathophysiology, the process begins with exposure to certain food antigens. The most common triggers are gluten and dairy, and proteins in these food triggers produce an abnormal immune response in susceptible patients. This leads to an inflammatory cascade with eosinophilic inflammation chronically in the esophagus, which can lead to remodeling. And the epidemiology of EOE has changed quite dramatically. So just 20 or 30 years ago, this was almost a case reportable condition. But now it's a very common mainstream diagnosis for gastroenterologists. And it seems to be happening quite broadly in Australia in particular, but in Western countries, particularly in general. And in young adults, EOE is now the most common cause of food bolus obstruction in emergency departments. There is also a strong link with atopic conditions such as asthma, and the majority of patients have one or more of these concomitant conditions. This means that, we need to be more alert to this condition, especially in PPI refractory reflux or dysphagia presentations. And it's not just an inflammatory condition. There is this progressive natural history that evolves if it's left untreated. So it progresses for more an inflammatory kind of phenotype, but the longer the duration of untreated therapy, untreated disease, it leads to more of a fibrostenotic phenotype with esophageal strictures. And we believe if we catch the condition earlier and treat the inflammation by various means, this is thought to reduce the risk of strictures developing. And diagnostic delay, every year of diagnostic delay has been shown to increase the risk of strictures by about 5 to 10%. So really, this highlights the importance of GPs in particular, or any frontline clinician, of recognizing it early so we can intervene and treat the patient before fibrosis sets in. So initially, patients may only have symptoms like dysphagia, heartburn, but the symptoms can vary between adults and children. So that in children, the patients can be rather non-specific with things like feeding difficulties, failure to thrive, sometimes even just abdominal pain and vomiting. So quite vague, probably just because of the difficulty ascertaining a history from a child. But it can be a mimic of reflux, and many of these patients are initially misdiagnosed as reflux, and only things come about when they present with a food impaction to the emergency department. So the diagnosis of EOE is made both histologically and endoscopically. While a normal esophagus has 0 eosinophils, so any eosinophils are abnormal, we use an arbitrary cutoff of 15 to discriminate between reflux, where you can also get eosinophilia, but typically lower levels. So we have to not only consider just the pure histological diagnosis, we have to correlate it with symptoms and exclusion of mimicking conditions. Biopsies have to be taken from multiple levels, and at minimum 6 biopsies need to be taken. It's a patchy condition, and our biopsy specimens are only a couple of millimeters in size. So if not enough biopsies are taken, then the condition can be easily missed. And I've come across this several times where a patient seems to clinically seem they have to have it, and all I do is take extra biopsies and we make the diagnosis. In some patients with EOE, you can't see anything endoscopically. So if they have symptoms, particularly dysphagia, biopsies have to be taken to rule it out. And while symptoms are important in assessing our patients, and obviously we want to get their symptoms better, they're not of its own a reliable marker of disease activity. So in general, we do need to rescope these patients when we commence any treatment to ensure it is having the desired effect in inducing histological remission. There is a lot of research going on into less invasive tests, and that can be done without endoscopy. And in the future, we may be able to diagnose this without, I guess, and monitor treatment response by doing things other than scoping the patients every time. So this is a sort of a broad overview of how I approach EOE, because I think there are two main components to the patient's symptoms that sometimes require different treatment. So certainly, almost by definition, every patient with EOE has inflammation in the esophagus, which is a predominant eosinophilic type of inflammation. And we have three broad treatment strategies for this. We have drug therapy with either topical steroids or PPI, but dietary therapy is also a valid approach to reduce the inflammation and can be quite successful. On the other hand, if we're dealing with a patient where stricture has already developed, and I would say the majority of patients with EOE at diagnosis do have stricturing present, then dilatation is the treatment for that, and often medications and diet won't have any effect on any established fibrosis. So I'll just give you a bit of an overview of the various treatment options that we do have available at present. So topical corticosteroids remain in a sense, the backbone of therapy in EOE, and they're certainly the most widely used and well-studied therapy in EOE. And we have multiple randomized controlled trials with various different formulations of topical steroids. In a sense, the beauty of this therapy is that it is a topical mechanism of action, and in a sense, the esophagus is kind of easy to get to. And by having this topical mechanism of action and having formulation of steroid with reduced oral bioavailability, we can get a good therapeutic response without the risk of systemic steroid side effects. And so this is the reason we can use these as a long-term therapy. In all the various formulations of topical steroids used in EOE, there's never been any report of any major long-term adverse effects. Particularly, adrenal suppression has been studied on many different occasions, and there have been no real trials showing that it causes cortisol abnormalities. The main side effect, which certainly is a risk, is local, and this is esophageal or occasionally oropharyngeal candidiasis. It may occur in about 10% of patients with EOE who are treated with topical steroids, but it's usually mild and asymptomatic and often is just an incidental diagnosis when we're performing endoscopy in these patients for other reasons. And in my view, when it's mild and asymptomatic, it doesn't need to be treated even. If it is more significant and causing problems, generally a single course of oral antifungal agent can be used, and treatment doesn't need to be interrupted. But look, there are the odd patient where recurrent candidiasis means we have to stop the therapy. There are multiple different formulations with a wide range in efficacy due to different delivery methods, dosages, and durations of therapy. For many years, we just had to use off-label asthma preparations such as Flixotide and Pulmicort, which we had to sort of in a complicated way instruct the patients to swallow instead of inhale, which could often be quite confusing for them. And these had reasonable efficacy rates, but in the last few years, the major advance in EoE treatment has been the first sort of licensed medication for EoE, which is a formulation of budesonide in tablet form, which dissolves on the tongue. And this unique delivery mechanism where it dissolves on the tongue and then the saliva is swallowed basically seems to achieve really high efficacy because it increases the amount of time that the medication dwells in the esophagus. These patients need careful counseling when prescribing topical steroids because essentially being topical, we don't want them to then wash that medication off by eating or drinking afterwards. So they have to be quite clear that they have to not have any food or drink whatsoever for at least half an hour after taking the medication. But when they take it properly, especially with the dispersible formulation, the efficacy is, extremely high in the order of 90 to 95% of patients achieving histological and symptomatic remission. The second broad group of pharmacotherapy is the proton pump inhibitors. And, we don't quite know exactly why these work. There is some basic science data showing that they possibly have a direct effect on eosinophils. Personally, I find this a little bit hard to believe, and I think that there must be some relationship between the acid suppressing effects of PPIs and their benefit in EoE. And I suspect that perhaps in some susceptible patients, it is actually acid reflux, which is the triggering factor for EoE. And so that's the way that PPIs help, though there's a lot of research still going on into this. As a group, definitely the efficacy rates of PPIs are much lower than the topical steroids. And depending on the trial, it's more around the 30 to 60%. And these ranges are even with high doses of PPI, so at least double dose. So, a small dose of PPI is probably going to have very modest effect on EoE. So even though their effectiveness is lower than topical steroids, they do still have a role because their benefits are, of course, they're much more readily available, they're cheap, easy to take. We have a long history of familiarity with prescription of them, of course, as doctors. And I think they specifically have a role in the patients, the subgroup of patients with EoE who truly have reflux or gastroesophageal reflux disease as well as EoE, because then you could potentially treat two conditions with one medication. So then moving on to diet as a therapy for EoE, and I'm a big fan of treating patients with diet, and I think it's not offered enough. So I think it's important we acknowledge that the empiric elimination diet is the accepted first line, is one of the accepted first line anti-inflammatory therapies for EoE. So it sits alongside drug therapy with sort of PPIs or steroids. There's not really any absolute contraindications, but I typically don't use this in patients with severe strictures because then you want to get their inflammation under control quickly and diet can take a bit longer. And it's probably not a great option for someone who also already has certain dietary restrictions because it might become too burdensome for those people. Um, in the studies done in centers of excellence with a lot of support with dietitians and things like that, it's been reportedly successful in identifying the triggers and inducing remission of the inflammation without drugs in up to 2/3 of patients. But there are several things that I discuss with patients when we're considering diet as a therapy. There can be a lot of misconceptions. So I do advise them that the foods that trigger their symptoms are not necessarily the ones that they're allergic to. It's usually not a direct, immediate contact allergy in EoE, but rather it's chronic exposure to a certain food antigen, which sets up a delayed but chronic long-term inflammatory allergic reaction. So you can't tell what the trigger food is just by what causes dysphagia. That's more related to the texture of the bolus. Unfortunately, despite a lot of effort, we don't have any accurate test to tell us what is the allergic food. So, for example, skin prick tests that an immunologist performs don't actually accurately tell us the allergen. So really, immunologists don't really have a big role to play in management of these patients. The skin prick tests are looking at IgE-mediated allergies, and same for RAS testing, but EOE is actually not IgE-mediated, even though it's associated with IgE-mediated conditions. Obviously, diet's not for everyone, and I would never pressure a patient into doing dietary therapy because it's not going to work. It has to be someone who's motivated themselves to do this, because especially in the initial phase, they do need to be strictly compliant. And of course, you need to tell them that there may be several endoscopies involved, because unfortunately, the only way you can actually tell if the diet is working is by repeating an endoscopy and taking biopsies and seeing if the eosinophil count has come down. So patients should not just be left on these highly restrictive diets long term. The aim is really to find one or at most two trigger foods. If they have any more than that, then no one can sustain restriction of more than two foods long term. And I would say even two foods is pretty difficult. Um, but, really the benefit is that there is the potential for lifelong drug-free remission if it works. And I think if my view is if we don't offer this to patients, then you never know. So some of the least expected patients are the ones who are really drawn to this because they don't like the idea of taking long-term medications. And finally, moving on to the slightly different therapy, which is esophageal dilatation. So this is unique compared to the other three therapies I've discussed already, because it's the only form of therapy that actually treats established fibrosis. But in saying that, it doesn't have any effect on the inflammation. So it's generally complementary to one of the anti-inflammatory therapies, because while treatment of the stricture can often give very rapid relief of symptoms when we dilate it, in general, the stricture will generally recur at some point. In some patients, that can be very quickly, within weeks or months, but in other patients, it will take a longer time and they'll be free of symptoms for a few years. But we can tell them that it will almost certainly come back eventually. Nevertheless, I think dilatation is an underused therapy in EOE, and I perform it a lot. I think, first of all, it is very safe. 20 years ago, there was concern that patients with EOE had higher risk of perforation when performing dilatation, but this has been disproven, and the risk is quite low and acceptable. Um, and the reason I think it's worthwhile doing is because strictures are often hard to see. Even if an endoscopy report says there's no stricture, we've actually published data from a big cohort at St. Vincent's to show that more than 50% of these strictures you can't actually see endoscopically. So it's a common cause of persistent symptoms when you don't know why a patient has ongoing dysphagia in EOE, and it's only dilatation that can help resolve that. And I think strictures do play a bigger role in patients' symptoms with EOE than we appreciate or realize. So moving on to the long-term maintenance therapy in EOE, this is a chronic condition. It very rarely just burns out or goes away. So we have to consider really from the time of diagnosis how this is going to be managed long term. So this graph on the left is a Kaplan-Meier curve from one of the topical steroid studies in EOE. This was a long-term follow-up of patients who were in deep remission after initial induction therapy with topical steroids. And then in long-term follow-up for 12 months, they randomized patients who were initially in deep remission, both histologically and clinically, to continue on the steroid, either at the 1 milligram or half milligram dose in the red and green, or to go on a placebo medication. And you can see by the 1 year mark, more than 70% of patients had already had relapse of symptoms. And this is just relapse of symptoms. If you actually look at the same study looking at relapse of histology, it's even higher. So, and we know from other studies looking at more longer term follow-up when drugs are withdrawn, at 2 years, almost every patient with EoE has relapsed, even if they were in deep remission. So I think we can very confidently tell patients that if they're, no matter how good they feel, if they stop their treatment, it will come back sooner or later. So it is inevitable, but the timing can vary. There is a group of patients, probably 20 or 30%, where they relapse histologically. So if we biopsy them, their eosinophils have become elevated again, but they haven't yet developed symptoms. We don't really have enough data yet to tell us the significance of this, but from our first principles natural history data in patients who've at first diagnosis, we suspect that these patients then, even if they don't yet have symptoms, it's inevitable that they will develop symptoms, and probably they have the higher risk of developing strictures if left untreated. So in terms of the data for maintenance therapy, the only high-level data we have in terms of RCTs at the moment is for this new formulation of budesonide, the dispersible tablet Jorvisa. And this suggests that, if patients remain on the drug, there is very little relapse, and it seems to be effective even out to several years. But in saying that, conceptually and based on some other weaker data, we think that if you get in remission by any means, whether that's PPI, steroid, or dietary therapy, if you stick to the therapy in general, relapse doesn't occur. It really only occurs due to stopping the therapy or non-compliance. Importantly, we know that maintenance therapy is safe. As stated before, there's quite a lot of good long-term safety data for topical steroids. And, from basic principles, it fits with the safety data that there are no major long-term systemic adverse effects because there is reduced oral bioavailability. So I think while this is a bit of a nuanced discussion, I think at minimum we have to be discussing with our patients early on in the diagnosis the pros and cons of maintenance therapy. And they need to be clear that if they decide to come off their treatment, and patients will often decide to come off treatment if they feel well. I think that's a natural thing that patients will try, even if you don't explicitly tell them to. They should be aware that the potential consequences of coming off their treatment include eventual symptom recurrence and potentially formation of strictures. So I thought perhaps this is something that you might encounter in the long-term care of patients as a GP, because usually once patients are stable, my practice is only to see them once every few years, and GPs certainly can prescribe these medications long term. So I think this may be a common question that comes up from patients. Doctor, can I come off these treatments, and do I need to stay on these forever? So I think, a simple thing is to just tell the patient the facts. I think the benefits of remaining on the therapy is that it reduces the risk of stricture formation and symptoms recurring. And the risks are really the risk of candidiasis locally in 5 to 10%, which is usually treatable. I think PPIs are safe. That's a whole nother discussion, but I think the risks are negligible. And diet in general, unless there is some history of eating disorders or anything, is generally no risk. And there's, of course, the inconvenience of treatments to consider, like the burden of taking tablets and cost, and obviously the burden of diet. But really, this is a summary of the pros and cons of continuing maintenance therapy. So there is no current universal guideline for maintenance, and I think these benefits and disadvantages have to be weighed up with the patient, and obviously the severity of the initial presentation has to be taken into account. So just a simple case of a typical patient with refractory reflux, and which highlights how easily EOE can masquerade. So this young man had been treated with PPIs for 2 years, but symptoms persisted. He finally presented to the ED with a food bolus obstruction, which is often how EOE is first diagnosed in young adults. And endoscopy showed some of the classic features like rings and exudates. Histology confirmed a heavy eosinophilic inflammation, and he was started on topical budesonide therapy and achieved symptomatic and histological remission. And 3 years later on maintenance therapy, he remains symptom-free and has avoided strictures. So it just illustrates the importance of early diagnosis and long-term management, because we could have potentially avoided this food bolus emergency presentation, which can be associated with significant complications like esophageal perforation in some cases. So just briefly again, talking about other differential diagnoses for refractory reflux in these PPI non-responders and broadly what I'd be thinking about. One group that certainly is not as common, but always has to be a differential, includes motility disorders. And of course, the most important one is achalasia. So these ones I would mostly consider if regurgitation is a prominent symptom or they have dysphagia. And we diagnose these by esophageal manometry. Of course, esophageal cancer is also a consideration, particularly in the older patient with more recent onset of symptoms and weight loss. Again, dysphagia is a red flag symptom here. There can be other less common causes of esophagitis. So reflux and eosinophilic are the most common causes of esophagitis, but occasionally we can get more unusual causes of esophagitis, such as other types of infective esophagitis, not just candida, but occasionally viral. And with these, the typical feature in the history that's a clue is odynophagia, or pain as the bolus actually travels down the esophagus. And we often see characteristic findings at endoscopy and confirmation on biopsy. Then I mentioned earlier this so-called syndrome of functional heartburn with almost identical symptoms to reflux, but by definition, normal investigation. I think we have to be very careful about this diagnosis and ensure we've really looked very hard. And I see a lot of patients with reflux type symptoms, and I very rarely make this diagnosis. I think if you look hard enough, you'll find another explanation. And one sort of unique condition which I wanted to talk about is this condition, RCPD, retrograde cricopharyngeus dysfunction. I would say most doctors still have not heard about this, but I'm very interested in this condition as we have now had a huge cohort of patients at St. Vincent's with this. And this is a rather unique and I think interesting condition in patients who have a complete inability to belch. And it appears to be an under-recognized cause of chronic GI symptoms, both upper and lower, really because they can't belch. They get trapping of gas in the gastrointestinal tract. They can have symptoms which mimic reflux. They classically get these gurgling noises from a lot of trapped gas moving about. And they also get lower GI symptoms, which is often misdiagnosed as IBS. And usually the inability to belch goes back to childhood. We published a cohort of these patients for the first time last year, which showed a few very interesting findings. We can treat these patients via endoscopy, injecting Botox into the cricopharyngeus muscle because it's non-relaxation of this muscle which causes the inability to belch. And they get a very astonishingly high cure rate and relief of all their chronic gastrointestinal symptoms in 85%. We also devised a diagnostic test for this condition because previously none existed. And I don't want to get too technical, but we have a patient on the left here having esophageal manometry, and we give them 1 or 2 cans of Coke because of all the gas it produces. And we see this pattern of gas building up in the esophagus to very high pressures. And unlike in a normal person on the right, we don't see any belching or relaxation of the upper esophageal sphincter. So that's that high pressure bar at the top there. And we can sort of very easily make the diagnosis, and treatment is often described as life-changing for these patients. So yeah, I just added that as a little point of interest at the end. So to summarize, one of the key points I wanted to say is that a patient with refractory reflux, think that it's not actually reflux. Consider other diagnoses. And particularly consider EOE as an increasing in incidence diagnosis, particularly in young patients, atopic patients, and especially when dysphagia is present. If we can recognize this earlier and diagnose it earlier, we can prevent fibrostenotic disease. And we have several effective and safe treatment options now for EOE: diet, steroids, PPI, and esophageal dilatation via endoscopy. And GPs, I think, should be feeling comfortable about managing this in the long term as part of shared care with a gastroenterologist, and should understand the nuances, hopefully, that was made clear about the pros and cons of maintenance therapy if needed, but emphasizing that it is safe. And finally, please ask about burping for patients with any refractory reflux or bloating, and you might find a very easy diagnosis that can be very simply and quickly treated. Thank you.
We did have a few questions come through.
Yeah.
Did you want me to read them out, or did you want to go through them and then answer them as you go? There's just 7 questions in that Q&A box.
Oh, okay. Yeah, I'll try and open it. Okay. So first question, do we have high eosinophilia in full blood count? Answer is yes, sometimes we do, but not most patients don't have a peripheral eosinophilia, so the absence of that does not exclude it. Yes, EOEs can, eosinophilic infiltration can also be found in the stomach or intestine. So we call these in broad eosinophilic GI diseases. So anyone with EOE are at higher risk of having those, but they're in general much less common than esophageal eosinophilia. So next is, can patients on Jorvisa still have live vaccines? Are they considered immunocompromised? Yes, I think they can have live vaccines because they do not, it's really a local treatment. So because there's a lack of systemic absorption, they're not considered systemically immunocompromised. Next, in patients with reflux symptoms but normal endoscopy, should they have esophageal biopsies to rule out EOE if it is persistent and non-responsive to PPI, but has some response to H2RA? Yeah, I think it depends on how good the response to H2RA is. If they initially present with a reflux phenotype and they have a good response to nizatidine or something, then I would say they don't necessarily need an endoscopy. It's more endoscopy would be useful in the patients who don't have a satisfactory symptomatic response to any type of acid suppression. Next, can Jorvisa be given to pediatric patients? Yes, I think it can. I'm not 100% sure about the Medicare, the PBS criteria, but yes, theoretically it can be given. I think it can. Next is long-term PPIs and risk of pneumonia. So I did briefly talk about PPI safety. Of course, this is an area of a lot of controversy, especially in the media. My view is a lot of the purported links, including things like pneumonia, dementia, even osteoporosis, they've all been purported links based on observational studies with relatively weak odds ratios, odds ratios compared to controls of often no more than 2. In an observational study, that's almost always due to confounding factors. And I don't think that there is any convincing risk of pneumonia or any other serious long-term adverse effects that has ever been proven in the literature. I think the most robust data for an adverse effect from PPI is intestinal infection. This has been found in RCTs in large cohorts that there is a slightly increased risk of intestinal infections, in definite increased risk in PPI users. And of course, there is a plausible biological mechanism for that. So my general advice is that PPIs are safe. Of course, we should use the lowest effective dose and attempt to wean them from time to time. But if patients are unable to wean and there is a good indication, then I think it is safe to use. My father couldn't belch because he had inverted stomach due to esophageal entry from underneath stomach rather than directly down into stomach. Yes, I acknowledge there are potentially other reasons for inability to belch. The most common other reason would be having a surgical fundoplication, which commonly causes inability to belch for different reasons. So I guess that's one of the reasons that we went ahead and devised a diagnostic test, because other causes of inability to belch wouldn't cause those kind of diagnostic findings we saw on the manometry. Finally, it seems to me that EoE treatment is symptomatic without affecting the disease because it recurs on stopping it. I wonder how contributory is microbiome abnormality, which can affect immune reactions, including asthma, eczema, and rhinitis. Or if you mean that EoE is the treatment is not curative, yes, I completely agree with that. In a sense, steroids and PPIs are sort of masking the treatment, just like steroids are treated for other immune-mediated diseases. They're not cures for the diseases. I guess dietary elimination comes closest to a form of cure in the sense, even though even that is not a cure, but it is effectively more looking at the root cause by removing the allergen. In terms of the microbiome, this is often invoked in all sorts of disorders these days, including immune conditions. Look, I'm not aware of any data specifically in EoE with regards to the relationship with the gut microbiome, but I would only say that uniquely EoE is a very local rather than systemic condition. But, I can't rule out something like that.
I think that was the last of the questions. Thank you so much, Doctor. We will now move on to our second presentation for this evening, Dr. Simon Ghaly.
So a slight change in tact with this second half of today's session, but we thought we'd keep the theme about inflammatory conditions of the gastrointestinal tract. So Santosh has spoken to us about the upper gastrointestinal tract and very common conditions affecting the upper GI tract. And today I'll be talking more of a focus on inflammatory bowel disease, with specifically Crohn's disease and ulcerative colitis. So what I hope to cover today is to run through an illustrative case, a very brief update in epidemiology, just to really highlight that these are common conditions and where we have some challenges and where I think the role of primary care can make a big difference, specifically with early diagnosis, an understanding of where and how we aim to treat IBD to achieve treatment targets in a timely way, and an overview of some of those therapeutic agents and drugs that we have available. So we thought we'll just have a poll first, just to try and understand who we have in the audience. So this poll is just asking how many patients with Crohn's disease or ulcerative colitis that you look after. And we'll give you just a minute to vote. Okay, so we're seeing here 30 people that vote, so roughly 50, less than 5, or definitely less than 10. And that would seem fairly average, I think, for most people in general practice. And so look, the first case I'm going to illustrate here is a man I had met 7 years ago. He was 71 at the time, diagnosed with ulcerative colitis at a very young age 17. And early in his disease course, he was quite sick, needed multiple hospitalizations. Though in the last 20 years before I'd met him, he had this milder disease course where he kind of grumbled along. He was on cilazapyrin twice daily, but he would self-initiate prednisone quite frequently. A few times a year at least, he would start back onto 60 milligrams of prednisone and wean over a 5 to 6 week period. Other immunosuppressants, in this case azathioprine, was briefly tried at one stage but was limited by fatigue, so never pursued any further. And obviously he was also under the supervision of a gastroenterologist during those years. His other comorbidities are listed here, nothing particularly unusual, except that he was needing regular iron replacement. He was still working in IT. He's married, his children grown and moved up. He was a keen dancer. That's a big thing, because sometimes when his IBD would flare, his joints would be involved as well. So he was generally reports feeling well. Nothing's really changed over the last 20 years. He'd have intermittent pain, recurrent iron deficiency, and he'd come and see his gastroenterologist, have his regular cancer surveillance scopes, and at times there'd be some very mild inflammation seen, but didn't have severe inflammatory activity. In 2019, so a year after I'd met him, the inflammation was looking a bit more significant in the descending colon. So illustrated here, is some of that ulceration, the loss of the vascular pattern, and some blood on the mucosa. And he was having 6 to 8 bloody bowel movements not too long before this, and had self-initiated on high-dose prednisolone. So this is another polling question. So just to check if you're awake, which of the following statements is incorrect? So which one here? There's only one answer. Which one is wrong? And again, we'll give you a minute. So a course of prednisone once or twice a year is okay. Colon cancer has increased. The risk is increased with long-standing colitis. Venous thromboembolism risk is increased with active colitis. Biologics can be safely used in the elderly. Okay, great. So interesting. I'm really happy to see that 60% think that a course of prednisone once or twice a year is not okay. So yes, we do not think that is adequate enough control in inflammatory bowel disease. There are other, I guess, autoimmune conditions where, particularly rheumatologists or immunologists may need to use long-term, low-dose prednisone, but that is not an effective treatment in inflammatory bowel disease, and associated with greater risks than any other drug available, with infection risks in particular, are steroids. And you don't need me to run through the long list of other complications. There are a few people in that poll that spoke about biologics, that being an incorrect statement about biologics being used safely in elderly, and certainly that has changed with some of our newer agents, that they can certainly be safely used in elderly patients. In fact, one of the challenges we have is that there is a reluctance to use effective treatment in elderly patients, and so they tend to be undertreated. So our man, Mr. MF, initiated on vedolizumab, and we'll talk a little bit about the different agents, but vedolizumab is a more gut-selective biologic where it limits trafficking of leukocytes into the gastrointestinal tract, whereas you have normal circulation to other other areas, so the risk of infections are very low with vedolizumab. He had an initial good response, but really 6 months later he flared and was back on prednisone. And so we did end up using a combination of infliximab with methotrexate, and these are systemically acting. There is risk of infection with these, but he has been the best he's been since, and that's sort of now 5 years down the track. He's not needed to be on prednisone, and he's maintaining an excellent quality of life. Unfortunately, hasn't suffered any infections, and I propose that his risk is actually lower than when he was using prednisone. So where are we at in Australia with IBD? So I thought I might just present some results. This is from the IBD State of the Nation report, which was an initiative from Crohn's Colitis Australia to try and understand a bit more about the burden of disease and distribution of disease. And so what we found is that we have approximately 180,000 Australians living with IBD. So that works out to a prevalence of 1 in 150. Most are young working age adults, and a significant proportion between the age of 19 and 29, a fairly even split between Crohn's disease and ulcerative colitis. So 1 in 150 Australians live with IBD, so it's quite common. These are the next two slides, I think, have important statistics that there is quite a delay in diagnosis. So more than 1 in 3 patients would have had symptoms for over a year before receiving a diagnosis in IBD, and 1 in 10 patients had reported that it took more than 5 years to get a diagnosis. The next thing is that how long it takes to get symptoms under control and to be in symptomatic remission, where 40% are reporting that it took more than 5 years before their IBD symptoms were under control. So clearly there's a gap here, and more needs to be done to try and get people into remission a bit quicker, and that'll be one of the aspects of this talk that hopefully I can deliver the message. So the prevalence of IBD is still increasing, and this graph really tries to illustrate the epidemiology of IBD in developing countries versus newly industrialized countries and in the Western world. So I guess we, as in the Western world, we saw that the incidence here in the orange bar, so new cases, was always gradually increasing between the 1950s and the 2000s, and that sort of started to plateau out in terms of the rate or the increase in incidence. But because these are lifelong diagnoses, we see this accumulating prevalence, and this is the stage of compounding prevalence which we're in at the moment in the Western world. As there's an aging population, you may see older patients with IBD that pass away. Then we may eventually reach this equilibrium where and then for the prevalence remain stable. But that's predicted maybe after 2050 that may be the case. And interestingly, we're seeing newly industrialized countries and following the same pattern of epidemiology. And so it's projected that we'll have nearly 280,000 patients with inflammatory bowel disease by 2030. And early diagnosis is really, really important. And so in this diagram here, you can see the this curve with the curved line showing episodes of disease flare and episodes of disease activity over time. And the more disease activity that you have, then you accumulate bowel damage, which I guess is strictures, developing fistulas and abscesses needing surgery. So we have this window of opportunity early in the disease course, before there are established structural damage to the bowel, to intervene, reduce the inflammatory component, and prevent complications, in some ways similar to eosinophilic esophagitis that we just heard about, with treating the inflammation and trying to prevent structural damage with stricturing. And so that's why this early treatment and diagnosis is important. So moving a little bit out to a case, talking about Stephanie. She's 26, she's a law graduate. She presents to her GP with 6 months of watery diarrhea. She's going 2 or 3 times a day with cramps and distension. A pretty unexciting past medical history. And I guess this next question is, what investigations would you want to request in Stephanie, really thinking between a very common scenario of differentiating between inflammatory bowel disease and irritable bowel syndrome? And this is the next polling question. I think this might be the last polling question as well. Can we bring that up, Bertha? Yep, here it is. So full blood count and iron studies, inflammatory markers, so CRP plus or minus an ESR, stool cultures and PCR, fecal calprotectin, all of the above. Yeah, no, so really good to see that. Yeah, all of these tests are exactly what we need to order in this patient. So, you know, we want to know whether patients are iron deficient or anemic, whether they have raised CRP, obviously ruling out infection, and fecal calprotectin we'll talk about has been a real game changer in terms of being able to identify patients early that need further investigations and expediting that process to try and avoid the statistic that I've just mentioned about the long delay to diagnosis. So I'm sure this is well known to you, but just to briefly run through the differentiation between IBD and IBS. So in IBD, we may see patients with weight loss, with bleeding. You know, waking up from your sleep to go to the toilet is not normal and rarely happens in irritable bowel syndrome. The symptom onset often in IBD is of, you know, measured in weeks to months, whereas IBS is often many months or years. We expect all of your blood work and fecal calprotectin cultures to be normal in IBS, whereas we may see changes on in your pathology in IBD, whether it's anemia or high inflammatory markers. We expect celiac serology to be negative. We should have added that in. That should always be the workup of IBS and the fecal calprotectin. So in this case, and often is the case that we, when we do calprotectin in primary care, it was in the intermediate range of 75 micrograms per gram. The bloods were all unexciting, negative celiac serology, normal cultures, CRP and ESR as normal. I should have put another polling question in here to find out what people would do with this result, but obviously we can't have a live discussion, so I'll just move on. That the current Australian guidelines and recommendations in dealing with fecal calprotectin for somebody who's younger than the age of 50 with no alarm symptoms, who's had their fecal calprotectin. If it's less than 50, then we can be happy to treat this as IBS. They don't need any further investigations. They don't need endoscopic evaluation. If it's in this intermediate range of 50 to 100, it's quite non-specific, and we'll go into that a little bit more. And these should just be repeated and reviewed within a few weeks. However, if it's greater than 100, then the chances of there being pathology, particularly inflammatory bowel disease, is higher, and even higher again if that level is greater than 250. And these patients should be, you know, referred on to rule out inflammatory bowel disease by endoscopy, plus or minus a combination of MRI or ultrasound. So I won't labor this too much, but in terms of what fecal calprotectin is, so this is basically a protein within neutrophils, and neutrophils will migrate to the site of inflammation or to an insult in the gut, and then release their granules. And so one of these proteins that's released physically into the stool is calprotectin. And so this really reflects inflammation within the intestine. It's not specific for inflammatory bowel disease. Infection can give you a raised calprotectin. Other conditions can give a raised calprotectin, but functional GI disease, specifically irritable bowel syndrome, does not give an elevated fecal calprotectin. And depending on the cutoff, but using the low cutoff of 50, this is a very sensitive test, meaning it's really good at ruling out inflammatory bowel disease if you have a calprotectin level less than 50. Where it lacks then is specificity. So if it's greater than 50, well then, it's not really specific to rule in or diagnose a disease. But a negative fecal calprotectin has a really high negative predictive value. It's really good at ruling disease out. But we use fecal calprotectin in lots of other ways as well. So in patients with established diagnosis of IBD, we use it to confirm disease activity. So we know similarly that if they have a level less than 50, then it's really good to rule out any active disease. And then as you go across with your thresholds, then that the utility of it changes. So if you have a level of 250, then there's a really high probability of having active inflammatory disease. And then we have this gray zone between 50 and 250. It's also really useful for monitoring patients who have inflammatory bowel disease. So this study here is looking at paired samples from patients. So when they have active symptomatic disease, they start on a treatment, and that drop in the fecal calprotectin in this study was highly predictive of achieving endoscopic remission. Patients who are already in remission, so doing regular calprotectins when they're in remission, can be predictive of those who are going to later have a flare. So this study is a fairly old study now, but looked at patients who were on infliximab for Crohn's disease, and that infliximab was stopped, and then they were monitored with regular fecal calprotectins every 2 months. And you can see in this bottom blue line that the serial increase over time of calprotectin was significantly associated with those who would relapse. And so you can see that really these calprotectins were starting to increase perhaps even 8 or 10 months before the flare. Certainly 6 months before the flare, you're seeing these change. And so that's why monitoring calprotectin, even in patients who are in remission, is quite useful. But calprotectin can go up in a range of other conditions, but we don't have clear cutoffs for FCP values for these other conditions listed here. In terms of Medicare reimbursements, and since 2021, it's been reimbursed for patients who have symptoms suggestive of inflammatory or functional bowel disease for more than 6 weeks. They had to be younger than 50. And the reason for that is that if you're older than 50, you've got new symptoms, and you probably needed to be evaluated, and more likely to need endoscopic evaluation, where infectious causes are excluded, low likelihood of a malignancy, and no alarm symptoms. And so this has been the MBS reimbursement for the last 4 years. And there's also an item number that if you do have an intermediate reading, that you can repeat it once. From 1st of November this year, after a lot of lobbying and work, that there will be new reimbursement for the monitoring of symptomatic inflammatory bowel disease. So people with diagnosed inflammatory bowel disease and have symptoms, then we can finally get calprotectin reimbursed for this indication. So that's one new change. So next we'll talk about remission and achieving our targets. And to know what the target is, well, we've got to define that. And are we talking about symptomatic remission, about feeling better? Are we talking about biomarker remission, or endoscopy, or ultrasound? And so the question is clinical remission enough, and what is clinical remission? And certainly clinical improvement and clinical remission is all we had to aim for and target up until even the late 1990s. Is all we were satisfied with was just clinical improvement. And these have been defined in Crohn's disease. Having no abdominal pain and normal stool frequency is the definition of remission. In ulcerative colitis, no rectal bleeding and normal stool frequency. As time has gone on, those targets have shifted to endoscopic remission, and even being proposed having histologic remission. And why? Well, achieving these targets is associated with much better long-term outcomes. So in ulcerative colitis, if you can heal the bowel, then you're less likely to have clinical relapse, less likely to need colectomy, less likely to need hospitalization, and more likely to achieve corticosteroid-free remission. And similarly, with Crohn's disease, you have much better long-term outcomes if you are able to treat to achieve the goal of objective remission, not just symptom-based remission. And I put these guidelines here because this is what we present to gastroenterologists in terms of the type of tempo with treating and trying to achieve endpoints. So in somebody who has active disease, that could be a flare, that could be new diagnosis, and you decide on initiating a treatment. Within a couple of months, you want to be seeing clinical response, a drop in CRP, a drop in fecal calprotectin. A few months later, by 6 months, you want to see, or even earlier, the CRP normalized, and then later it takes a bit longer to have complete clinical remission and a normal or fecal calprotectin less than 250. And then in the long term, usually greater than a year, can we expect complete endoscopic healing, normalization of quality of life. And there's emerging roles for ultrasound, which we'll talk about. And, I guess these exact timelines, are somewhat arbitrary. But the point and the reason I present this here is that this should be a dynamic, active process of persistently trying to readjust things to achieve the target of remission. And it shouldn't be like the first patient who I presented where he's grumbled along for 20 years needing repeated courses of steroids. And I think this is important for you all to be aware of, because if your patient is under the care, and most of these patients are under the care of specialists, but this should be the expectation. And I put it to you to challenge any treating specialist if it's not clear that treatment has been at a reasonable tempo with attempts to achieve these harder endpoints. And so we made this point already, but just conceptually, if we have a target that we want to reach, we need to be constantly reassessing and adjusting our treatment. So we may start on a path, but unless we do tests and reassess, then we don't know that we're going off course. And so repeatedly doing tests and assessing clinically and readjusting treatment, then that's really the only way that we can achieve our targets. And this has been shown in a large randomized study called the CALM study, which looked at patients with Crohn's disease and were randomized to just standard care based on symptoms and physicians ordering biomarkers when they thought was appropriate, versus a very regimented, tight control where set parameters were in place and treatment would be escalated, even if symptomatically patients were in remission, if the objective tests were still showing inflammation. And there's a statistically significant and clinically meaningful increase in the rate of being able to achieve endoscopic remission in those treated with tight control compared to the standard management. And this standard management is probably higher than results higher than what would be seen in real world, because all these clinicians were still aware that they're in a trial. Like I said, calprotectin has really made a big difference and has made this a lot easier to achieve in a non-invasive way, because patients don't want to have colonoscopies every few months to know how they're doing. And having a calprotectin and furthermore having a funded calprotectin makes this a lot easier. And we now also have data to show that a fecal calprotectin that's less than 250 and certainly less than 150 is associated with endoscopic remission, and less than 60 probably also associated with normal biopsy. So this has meant that we don't need to do colonoscopies as frequently and quite easily can defer that first colonoscopy to 12 or 18 months after the initiation of a new treatment. In patients who are in remission, how often should they really be reviewed? And this is talking about how often should they really be having specialist review. And so, we would tell gastroenterologists they should be seeing patients in remission 6 to 12 monthly. They should be having their blood test, depending on what drugs they're on, between 3 and 6 monthly. And this key here of objective disease assessment twice a year, whether it's fecal calprotectin or ultrasound. I've mentioned ultrasound a couple of times, but just to let you know, this is specific bowel ultrasound, and it's a very useful tool. And this was a survey talking to patients about what tests they preferred, and patients preferred to have an ultrasound over even submitting a blood sample or a stool test. It's a non-invasive, a very non-invasive test. In fact, even one of the challenges with calprotectin is patients don't like doing stool samples. They don't like submitting poo samples for calprotectin. So the return rate at best is about 50%, whereas ultrasound has high acceptability. So what is it? So these are it's a non-invasive transabdominal approach. Transperineal is only looking at patients with fistulizing disease. We rarely do this. There's no need for bowel preparation or fasting. The total procedure time is about 15 minutes, and we're one of the few centres here at St Vincent's that actually do this in New South Wales. We're certainly the biggest centre in New South Wales. There are 2 other hospitals that do it routinely, being Liverpool primarily and St Vincent's. So we are looking to assess the transmural disease activity, so particularly looking at bowel wall thickness. How thick is the bowel wall, the sign of inflammatory disease, and where that disease is. And we can also see complications. So it's just another option for non-invasive testing, and this is something that has been widely used for many years in parts of Europe and has really expanded in Australia, mainly in the space of inflammatory bowel disease units. So I guess you maybe want to about new therapies in IBD. So look, obviously this is really going to be in the realm of what your gastroenterologist or the IBD unit is going to be prescribing. However, I think it's important to know what's available and what's out there so that you can be sure that your patients have, potentially have options available to them. And so traditionally, our first agents were the anti-TNF. So this is your infliximab, so your and adalimumab being your Humira, and Remicade being the brand names. Golimumab, which brand is Symphony, is not used as much, but these are all available now in subcutaneous form, and infliximab in infliximab form, in IV form. Look, we still use a lot of anti-TNFs. These are effective treatments. They're fast. We have become very good at monitoring drug levels and optimizing their use. They're safe in pregnancy, and they're very effective for the extraintestinal manifestations, whether that's peripheral arthritis, ankylosing spondylitis. Downsides that even though they're really good at working initially, they have higher rates of losing response over time. There is more systemic immunosuppression, and with that comes a higher risk of infection. Then came along anti-integrins, so vedolizumab is the drug name, Entyvio being the brand, and that's for both Crohn's and UC, intravenous or subcutaneous administration more recently. The big advantage of this drug is its safety. It probably has one of the best safety profiles with virtually no increase in infection risk, and these are effective, durable agents. The downsides are they probably not as potent as anti-TNFs. They have a slower onset of action. There's limited pregnancy data, but the data that we have is very reassuring, and we're generally happy for patients to be on these during pregnancy. The next group of medications are the IL-12/23, and so the main drug here, or the only drug, is ustekinumab. That was always Stelara. There's now a biosimilar of it available called Stekimer. So again, similar to vedolizumab, very safe. It's effective, not quite as good for extraintestinal manifestations. It's given as an initial intravenous dose and then subcutaneous injection every 8 weeks, and it's licensed and available on the PBS for both ulcerative colitis and Crohn's disease. This group of agents have now been available for 3 or 4 years. These are the JAK inhibitors. These are oral agents. The brands are Xeljanz or Rinvoq. Rinvoq is approved and being used in both ulcerative colitis and Crohn's. Xeljanz in only ulcerative colitis. These are highly effective agents. Despite being orally administered, they're effective for both extraintestinal manifestations as well as for the actual bowel disease. There is some downsides to them, though, particularly on the higher doses with Rinvoq acne, Shingles is without doubt an issue, and this is where we're asking all the patients to get their Shingrix vaccines before starting, if possible. There was some safety signals, particularly in the rheumatoid arthritis population, but on the higher doses, we've seen more DVT-PEs. That's also seen in smokers. And there was concern about increased cardiovascular risk in a study of older rheumatoid arthritis patients with risk factors. We can't use any of these therapies in pregnancy. We don't have any data on their safety. This is again a yet even newer group of sphingosine inhibitors. Some agents of this are being used in multiple sclerosis, not these particular drugs. And we have two medications, ozanimod, which is Zeposia, and etrasimod, which is Velsipity, in ulcerative colitis. These are effective agents. They haven't been around for very long, and so we don't have a great number of patients on them, so you may not have seen these at all in your practice. There is some caution about it causing macular edema, so we're about it in diabetics. We just get their eyes checked. Patients with conduction defects, all patients probably get an insignificant reduction in heart rate, but if they have conduction defects to start with, that could be more of an issue, and again, contraindicated in pregnancy. This last group of agents are IL-23 inhibitors. These aren't available yet on license in Australia. They are available overseas. Again, very effective agents, similar pathway to ustekinumab, and we are hoping very much so that these will become available in Australia on the PBS in a not too distant future. So in terms of referral pathway of patients who you suspect may have inflammatory bowel disease or have established inflammatory bowel disease, so if it's from the St. Vincent's, sort of our local area, they can be referred to the IBD clinic, which we have 3 nurses, dietitian support, a pharmacist, our registrars, and 3 consultants, and the online referrals available from the hospital website, or that's our email. And in private practice, certainly here at the Diagnostic Endoscopy Centre, we can see them as well. So, look, I guess the key takeaways I was hoping to deliver today is that IBD is common, and as a GP, your role in early diagnosis is key, and the Calprotectin now offers us a very useful way to expedite that diagnosis. Proactive treat-to-target approach is now the standard of care of IBD in 2025, and I encourage you to challenge your physicians to be aggressive in their treatment if that's not happening already. And we have a number of non-invasive monitoring tools to enable this proactive treatment approach. I hope I've shown you that we have many advanced therapies, and more will be coming, and so that your patients should be also aware that there are treatment options available to achieve those harder endpoints of endoscopic remission. And so on that note, I'll finish, and happy to take any questions. So I might open the Q&A. So the first question I've got here is about the evidence of FMT inducing cure of IBD, especially ulcerative colitis. Do you have any comments? So yeah, thanks for the question. So FMT is a really exciting area. This is fecal microbial transfer, so taking healthy feces from a donor and infusing that either at time of colonoscopy or through capsule to somebody with inflammatory bowel disease. So where we're at with this data, and St. Vincent's was part of 2 seminal randomized controlled trials published internationally looking at FMT, specifically in ulcerative colitis, I should clarify. In Crohn's disease, it hasn't been as promising. But certainly in patients with mild or moderate ulcerative colitis, FMT has been shown to be able to induce remission. The big question is about after that course of treatment, how long can you maintain the response? Our observational data is that most patients without any form of maintenance FMT would relapse, in a small cohort of patients where we've tried maintenance oral capsules of FMT, then you might be able to maintain the remission. But I have to say, this has really been for a subset of patients with that milder disease phenotype. Anybody with severe disease who'd failed multiple biologics didn't seem to do as well. So, definitely not a cure, but certainly a treatment option. And the field is now moving to try and understand the microbial basis for this and seeing whether, the learnings at a microbial level from FMT may help develop other specific treatment options. So what are the long-term treatment complications of vedolizumab after 5 years use? If patient is cured with vedolizumab after 5 years, is the risk of colon cancer still high? And do we need colonoscopy? So we haven't seen any long-term complications with most of our biologics. I think with probably the data with infliximab is the longest lasting. We haven't seen increased risk of solid organ cancers. There's some controversy about maybe a trend for increased melanoma and lymphoma possibly, but we're talking about very small effect sizes. And we certainly haven't seen that with other agents. And so patients can be in long-term remission, certainly can be in remission for 5 years. That's still not a cure, because if with all of our studies stopping the drug, the majority of patients will flare within 5 years. Well, 50% will flare within 12 months, and then 70 to 80% will flare within the first 5 years of stopping a biologic. And most of those studies come with infliximab. But the point about colon cancer is true, that one of the greatest predictors of cancer risk is not just the duration of therapy, the duration of disease, but how long they've been active during that time. So yes, we do regular surveillance after disease diagnosis by 8 years, where the colon has been involved specifically. This doesn't apply to small bowel Crohn's, but with colonic Crohn's or ulcerative colitis. So it's the duration of time that it's been active. And so yes, the disease risk is high if they've been active during that time, but even when they've been in remission, they're still enrolled in a surveillance program. I guess where it affects it, and they all do need colonoscopy, but it's the frequency of colonoscopy that changes. So somebody who has the normal looking colon, has been in remission for a long time, they don't need yearly colonoscopies. So they're the ones that would go out to 3, maybe even 5 yearly colonoscopies for surveillance, but they still do need surveillance. So next question is about elevated fecal calprotectin and intraluminal thickness of the terminal ileum on CT scan and on colonoscopy. Is it enough to confirm IBD and initiate treatment in a younger patient with bowel symptoms of bloating and burping, no diarrhea? So look, I think the diagnosis of Crohn's disease is such an important diagnosis with long-term implications. This is a lifelong diagnosis. So that initial evaluation and tests is so critical, because we're talking about long-term maintenance, potentially immunosuppression. And once we start introducing different treatments, it can make it more difficult to ever have a definitive diagnosis. And so even with an elevated fecal calprotectin and imaging findings, we would still need that colonoscopy to visualize the disease and take biopsies, because we don't have one single test that's an absolute gold standard, and it's often a combination of tests that are needed to increase the confidence in that diagnosis. And so, very rarely would we say that imaging and a calprotectin is sufficient. That would be an exceptional case, even in young patients. So I would have to say that generally speaking, virtually all patients would need to have a colonoscopy, as well as likely imaging and biomarkers. Do patients go into remission during pregnancy and can go off medication? I'm so grateful for whoever's asked this question. I think it's a question we get asked all the time, and often a misconception. So the statistics on this is it all depends on where your disease is at before pregnancy, before conception. So patients who are in remission before they conceive, they have a 2/3 chance of remaining in remission and a 1/3 chance of flaring during pregnancy. If you have active disease before conception, you have a 2/3 chance of continuing to have active disease during pregnancy, and only 1/3 or less even of going into spontaneous remission. So the short answer is that if you're active before, you're likely to stay active. Yes, some people go into remission, but that's still the minority. And so the key here is for our patients to have an active conversations with their GP, with their specialists about pregnancy plans to really ensure that they are in deep remission before they start trying to get pregnant, because your pregnancy outcomes are going to be predicted by how well you were before getting pregnant. So I think that's the last of the questions. So thanks everybody for being involved and answering the polls, and thanks for your questions, and thanks for having us tonight.
Thank you so much, Dr. Ghaly, and thank you very much to both of our speakers, everybody for attending and your participation. The evaluation survey will pop up on your screens once we are finished, and we look forward to seeing you at the next events. Thank you very much. Have a great night.